I would like to say thanks to the organizer for giving me the opportunity. The topic that I am going to cover today is device closure of hypertensive PDA. Okay, so the highlights of my topic today will be what is hypertensive PDA, oh, when to close it and when not to close it. That I think that is the most important challenge, how to assess the operability of the hypertensive PDA. And the third, I shall briefly tell how to close it. So just to emphasize on the fact that deciding the operability is most challenging, I shall start my presentation with few practical case scenarios. The first case was done long back in 2007 by two very pediatric cardiologists. It was 8-year-old girl, 9mm PDA, borderline operability. So they did a cardiac cath in room air. The 7.9 QPQS ratio was 1.8. They did an oximetry, PVRI came down to 6.6. Test occlusion was not done because probably at that time it was not that popular. So probably based on that time's guideline, they closed the PDA with a 14mm muscular device. The patient persisted to have pulmonary hypertension, started on single pulmonary vasodilator, then dual agent. There were recurrent syncopes and RV dysfunction, and the patient died in 2018. So probably not a correct decision. The next case scenario, 10-year-old girl, it was done recently, 2019. 10-year-old boy, 98% saturation, large PDA, dilated left heart, severe pulmonary arterial hypertension, taken in cath lab, room air data, PVRI of 4.9, QPQS of 2.9. After giving 100% FiO2, PVRI came down to 3.2. We got a test occlusion also. Both the diastolic and the systolic pressure ratio were less than 50%. So everything was telling this is an operable case. We closed the PDA with a 14/12mm duct occluder, no residual pH during the follow-up. So if we see these two cases, the workup was much more complete in the second case, as probably the guideline for PDA closure now is much more clear-cut. But there is a big but. Look at the third case. Again, done recently, 2018. 18-year-old female, lower limb saturation 95% after exercise. 10mm PDA, continuous left to right shunt, 16/2 pressure gradient across the PDA, significant flow reversal in the DTA, dilated all four cardiac chambers, X-ray wise pulmonary plethora was there. So clinically, clearly operable. Taken in cath lab, room air data, 11mm of mercury systolic separation. QPQS room air 1.9, PVRI of 7.1. We were pretty sure that this patient is operable. We didn't do a 100% FiO oximetry study. Directly, we put a 14mm muscular device just to do a test occlusion. After 15 minutes of test occlusion, PA pressure has fallen. More than 30% fall in the PA systolic pressure. And the diastolic pressure also, there is a fall and there is a diastolic separation between the aorta and the PA. But if you look carefully, the systolic pressure fall, the systolic pressure ratio was around 0.6. It was not less than 0.5. So these are the angios, large PDA. This is the post closure after 15 minutes. There is a significant flow across the device. So we thought the inadequate fall in the PA pressure may be due to this inter-device flow. We released the device. After releasing, you can appreciate there is significant pulmonary plethora also. And as the patient was having pulmonary hypertension, we started on sildenafil after closure. 3-month follow-up, PR gradient of 80mm of mercury. The patient was started on bosentan. Doubtful drug compliance, irregular cardiac follow-up. At 11 months of follow-up, we did a repeat cath. Room air data, PVRI of 8.6. After giving oxygen, PVRI came down to 4.9. There was moderate pulmonary arterial hypertension. So despite of having all the clear-cut ideas, our decision was not proper. Now the patient is class 2 symptoms on pulmonary vasodilators. So that is the challenge. What is hypertensive PDA? Large unrestricted or minimal restricted PDA with severe pulmonary arterial hypertension. Main challenges in the management. First, and the most important thing is the deciding the operability. Next is choosing the proper device. So if we divide the hypertensive PDA, we can classify them in 3 different groups, as we all know. Group is the operable, where we have to close the PDA. The third group is the inoperable group. We cannot close the Eisenmenger syndrome. The problem is in between, borderline group. We have to check whether they are still operable or not. Majority of the time, they are bigger kid, minimal symptoms, clinically not much hyperdynamic precordium, no continuous murmur, maybe short systolic murmur may be there. lower limb saturation around 90 to 95% at rest and after exercise, but definitely more than 90% after exercise, because majority of the studies showed if the lower limb saturation less than 90, it's clearly inoperable. Chest X-ray, cardiomegaly, not much plethora. ECG wise, biventricular hypertrophy. Echo wise, predominantly left to right shunt. So how to assess the operability? In cath lab, we have to perform these 3 steps. First, room air oximetry study, the calculation of PVRI, QPQS ratio, and the resistance ratio. Then we have to perform vasoreactivity testing. In our cath lab, still we are doing with 100% oxygen for 15 minutes. Then we have to do a trial PDA occlusion, either with a device or with a balloon. So in other shunts, we are never using this test occlusion. But why in PDA we are using this? Because oximetry study is a poor predictor of post-procedural pulmonary hypertension, and there are multiple fallacies because of the precise streaming of the ductal flow. Then we can directly go for a test occlusion without doing oximetry, just to assess the operability. Why oximetry is still necessary? Because if the baseline QPQS ratio is less than 1.5, baseline PVRI more than 9, and resistance ratio is more than 0.5, better not to perform a test occlusion, because there will be significant hemodynamic compromise. And as per latest AHA ATS guidelines, still as a shunt lesion, we have to calculate PVRI and the resistance ratio to check the operability. Few comments on the trial occlusion of hypertensive duct. The purpose is to decide the contribution of the left to right shunt on the PAH, and it has been found to be a strong predictor of persistent post-closure pulmonary arterial hypertension. We can do with a device or with a balloon, and we have to measure the simultaneous PA pressure and the systemic pressure for at least 15 minutes. What are the parameters to be checked after occlusion? Again, there is controversy because multiple studies have taken multiple parameters. The first big published study, Ian et al. In 2007, they have taken fall in the pulmonary arterial systolic pressure, no decrease in the systemic aortic pressure, and no worsening of the clinical signs and symptoms as a marker of operability. In 2008, Sangeeta Viswanathan and Krishna Kumar sir, that paper, they have proposed more than 25% fall in the PA pressure after balloon occlusion and more than 50% fall in the diastolic pressure ratio. The fallacy is, if we put a sheet across the pulmonary valve, there will be severe pulmonary regurgitation, which can result into fall in the diastolic pulmonary arterial pressure. In 2012, Valgat and Dr. Bharat Dalvi et al. In Annals on Pediatric Cardiology, they have proposed fall in systolic pressure, pulmonary pressure more than 20% of the baseline should be taken as a parameter for operability. The latest paper in 2014, Duan Zheng et al. This is the most popular and widely used criteria. Post-occlusion PA pressure, the systolic pressure ratio, that is the systolic PA pressure is to aortic systolic pressure, should be less than 0.5. Again, the fallacy is this study was not validated by a post-procedure cardiac cath follow-up. And if you go to the detail of this paper, among 137 patients, 7 patients had persistent pulmonary arterial hypertension despite of fulfilling this criteria. So the most important question, when not to close a hypertensive PDA? If we remain strict in our guidelines, then if the PVRI more than 6 would unit meter square, and if the resistance ratio more than 0.3 in baseline and after vasoreactivity testing, if after post-occlusion the systolic pressure ratio is more than 0.5, we should not be closing the PDA. Rather, that we can continue pulmonary vasodilator for 4 to 6 months, and then we can repeat the cath to assess the operability. Another important factor, we have to take the follow-up data. The hallmark successful closure is normalization of the PVR. If we can document a PVR less than 3 closure, then that indicates a successful PDA closure. And ideal time of catheterization is at least after 1 year of the procedure. But there is paucity of data. None of the published studies have taken this follow-up cath data. So there is no established guideline for the test occlusion, proper device selection, and the follow-up cath study. Now coming to that.
Even if you can, because in the interest of time.
Yeah, sure. So we can use many devices. These are the few examples. We can use a routine duct occluder, ADO 1. We have to oversize because this is a single disc. We are routinely using this muscular VSG devices. We can use post-MI device. The advantages are the length of the device is bigger and the retention skirt is slightly bigger than the muscular. In a tubular duct, we can use a oversized AVP 1. Few cases we have used ASG occluder also, particularly in a short duct or a window type of duct. I don't have the images right now. So there is scope for further modification. In a really borderline cases, we can go for a partial ligation of the PDA, so that just to take out the contribution of the PDA, but keeping the pop-off open. There is another concept, transcatheter closure using a fenestrated or a stented device, proposed by Amar Matub, Gareth Morgan et al. In 2020 in Progress in Pediatric Cardiology. So to summarize, taste occlusion of the PDA is most important predictor of persistent pulmonary hypertension. But to check the operability, we have to consider both the oximetry and the taste occlusion. And operability is indicated by fall in the systolic pressure ratio by less than 0.5, and the PVRI and the resistance ratio less than 6 and less than 0.3, either in baseline or after reactivity testing. And to establish a proper guideline for operability, we need more follow-up data with catheterization performed at least after 1 year of the closure. Thank you. I would like all of you to invite for in City of Joy, Kolkata for PCSI 2022. Thank you.
Thank you, Dr. Sanjeevan. It was indeed